Welcome, Dr. Kumar. It's a pleasure to have you as our next guest on our Doctor Marketing Agency podcast. It's a pleasure to be able to connect with you, and I'd like to just hand over the opportunity for you to just introduce yourself prior to us to go into the actual conversation around limb loss awareness and foot health awareness and how it impacts patients.
Yeah, thank you, Win, for having me on your podcast for discussing the lower extremity diseases, and the joints and the role of the vascular medicine here. You see, I'm a cardiovascular specialist and practiced for the last over 30 years. After finishing from UCLA in early 90s, I came to Bakersfield. And since then, I've been practicing as a cardiovascular specialist. We started as mostly in cardiology. At that time, there was not much that we could do for the vascular optimization for the lower extremities. However, in the last 10 to 15 years, the technology has improved so much that has allowed to go into the smaller blood vessels. We started to go in large blood vessels 30, 40 years ago. We used to treat the aorta and the major arteries. Then the era came that we were able to treat the smaller arteries, like in the coronary arteries. And that's why we are especially, like interventional cardiologists are very especially attuned to this small blood vessels management. And so when we had that experience of the coronary arteries and the technology became such that we could look into the arteries in the legs, until 15 years ago or so, we wouldn't treat any disease below the knee in the blood vessels. Okay. And then we started to treat the below knee vessels like the tibial arteries. Then the technology came even further, and the microvasculature we started to go in. Before, let's say 2010, we would not treat much below the knee and then these 2 to 3 millimeter vessels, just like coronary arteries, we started to treat that. In the last few years, we have started to go in below the ankle now. We are able to treat these arteries, which are 1 to 2 millimeter vessels. However, in the last 2, 3 years, we are able to now enter into these 1 millimeter or smaller vessels. And that's where we are making a lot of difference in these joint pains and arthritis, because now we understand how to check for this chronic inflammation by angiograms. We didn't know how to check for that until a few years ago. Okay. And we are able to check that, and we are able to treat and stop the inflammation with these new procedures that we're going to talk about today.
Well, that's fantastic, Dr. Kumar. I mean, you're definitely a veteran, having been doing this for over 30 years, and you touched on some important points, as an interventional cardiologist as well as a vascular surgeon. I think what's important is that, April is Limb Loss Awareness Month, and that ties in a lot of the times to peripheral artery disease. It's a diagnosis and a disease that doesn't get a lot of attention that it should. But, it'll be interesting to note that 1 in 20 Americans are diagnosed with this disease. Over 12 million Americans have peripheral artery disease. And in severe cases, this leads to limb loss. So in terms of, your knowledge and expertise, what would you say is important when it comes to the risk factor control when we talk about peripheral artery disease and how that could potentially lead to lower limb loss?
So peripheral artery disease, as opposed to the coronary artery disease, is mostly asymptomatic. We know that the coronary artery disease, patients with heart attacks or blocked arteries in the heart, about 70 to 80% do have some sort of symptoms, which we call them anginal symptoms. Of course, in diabetics, that number is a little bit lower. Diabetics patients up to 50% may have no symptoms even with the heart attack. Okay. But majority of the heart patients do have some sort of symptoms that they come with some chest pain or shortness of breath or some palpitations, dizziness, some sort of symptoms that we are able to check their heart and fix it. With the lower extremities peripheral artery disease, majority of the symptoms majority of the patients don't have any symptoms. More than 80-90% of the patients, uh, they think, oh, this is part of the normal life to be not be able to walk that much or going to malls. We are getting older, or this numbness in the feet, or they feel a little bit off balance, or this is just part of the old age, because there is no typical pain in the legs or the feet with peripheral artery disease. You have to really pay attention. And then other problem that we are seeing now, the disease of the peripheries or peripheral artery disease that used to happen in the major arteries, we don't see that much anymore. Those patients we pick up early and they can be, of course, fixed. The problem now is the small vessel disease, like diabetics. Diabetics people, we don't see that much disease in above the knee arteries. It is mostly below the knee arteries in the small vessels and desert foot, or even in the foot, the very tiny arteries, they just don't have much blood circulation there. And then they may start not having any symptom. Actually, they don't have much symptoms. They may feel the numbness and that masks the pain. Okay. So what is happening is in patients, especially with diabetes, the small vessels that supply the foot, they may not feel the symptoms, and then some injury happens, an ulcer or a wound happens, and that now doesn't heal because there is no blood supply. But when you try to treat these patients, you look at their arteries and they're all so much blocked that not much can be done, and you end up needing amputation. And that's where we have to make a lot of uh, difference. And the difference starts from identifying these patients who are at risk, like we were talking about the risk factors and how we can reduce their risk for having peripheral artery disease and how we can reduce their risk for having amputations.
Yeah, that's very interesting, and I think you on point there, Dr. Kumar. So I was talking about this risk factor control, and I mentioned specifically cholesterol management, blood pressure control, diabetes optimization, as well as smoking cessation support. Dr. Kumar, would you say that these are key factors in playing a role if a patient is diagnosed with peripheral artery disease or not?
Absolutely. This is very critical actually, because two most important risk factors for the peripheral artery disease are smoking and diabetes. Okay. If somebody has no diabetes or no smoking history, it's very uncommon to develop serious peripheral artery disease. However, if somebody has a history of diabetes of over 10 years and they have history of smoking and they are smoking currently, then more than likely they do have peripheral artery disease. And I would go on to say even that unless proven otherwise, I would assume they have peripheral artery disease, and we need to check for that.
Okay, for sure. So, Dr. Kumar, are there any medications out there that you would recommend as a cardiologist and as a vascular surgeon that could improve the blood flow and also prevent any clotting that could lead to a risk when it comes to these lower extremity, diagnosis of these diseases like peripheral artery disease?
Yes, absolutely. The peripheral artery disease, the recommendations are use antiplatelet medications. What these are, like aspirin or Plavix or medication like that, they'll reduce the risk for the clot development on top of the plaque. What happens is the plaque builds up slowly over the years, and this plaque is composed mostly of the cholesterol and the fibrofatty material. Once this plaque develops, then sometime in future, with stress or inflammation, this plaque may rupture, and that invites a clot formation on top of the plaque, and that's what hits these arteries, and they become blocked. This clot is the final pathway through which these arteries block usually. And the medications are used to prevent this blockage is, number one, we have to make sure the plaque doesn't build, and that's the control of the risk factors like diabetes or cholesterol or high blood pressure or smoking. Okay. Once we reduce those risk factors, then the plaque will not become that big or will not grow. Okay. Second thing we have to do is prevent this clot formation as you were mentioning. And the main medications that helps there is either aspirin or Plavix. And the current recommendations are we can use either one of them. We don't have to use both unless the patients are extremely high risk or they had any revascularization or angioplasty or some serious continued blockage and thrombus formation on those.
Okay, so that's the perfect point that brings me to my segue there, which I would like to, touch upon, Dr. Kumar. We talk about endovascular intervention. At the top of the podcast, you mentioned an angiogram. And then we speak about the different treatments that are available when it comes to peripheral artery disease. We talk about, balloon angioplasty. Can you perhaps go into, the whole process of endovascular intervention? Would it be a situation where atherectomy is needed? Could it be a situation where you mentioned this plaque buildup or atherosclerosis? Just so that we can kind of get that education piece as to what you would recommend, depending on the situation and the stage, when it comes to endovascular intervention.
So let's say we first try the medications to reduce this plaque and reduce the risk factor and modify the risk factors. Also give these antiplatelet medications. So in general, if you have to just remember one thing, aspirin and statins, that's what we'll say that most of these atherosclerotic plaques or patients with atherosclerotic cardiovascular disease, we treat with aspirin and statins. Having said that, of course, this doesn't just mean aspirin only. Aspirin is like Plavix or statins, maybe different cholesterol reducing medications. Plus, a good control of the blood pressure or avoiding smoking, a good control of the diabetes. Those are the risk factor modification. We start with those, ask the patients to watch their diet, to walk or exercise if they can. A lot of these patients are older age, they may not be able to exercise. They have other problems like joint problems and things like that. So it's very difficult for them to exercise also. But whatever you can do, whatever they can do, they have to push themselves to do a little bit more to have those, they improve the blood flow into the legs. Let's say if this doesn't work, we of course diagnose these conditions by doing some, let's say ABI or the arterial duplex studies or the CT angiograms or the MR angiograms. There are many things we do. Arterial duplex study is a very quick test that's done in the office setting, takes about 30 minutes or so, and we can tell pretty much how much is the blockage and where it is before we do the angiogram. And so once these patients have failed the medical therapy and their symptoms are progressing or they develop some ulcers or gangrene, it's time to look into the arteries and try to improve the blood flow there. Okay. And that's what we call the angiogram. During the angiogram, we put a small tiny catheter thread into the one of these arteries, either from the foot or the groin or from anywhere else in the body, many places like radial arteries. Once we do the angiogram, we are able to map those arteries and be able to see where the plaque is, how big it is, how much is it blocking. There's usually we see these plaques at multiple levels in the lower extremities actually, as opposed to the heart, where usually we'll see one or two places and we put stent on those places. Heart arteries are only about, let's say, 5 to 10 centimeter long. However, we are dealing with these arteries like almost 100 to 200 centimeters long,
Right.
So these are like a large area of the arteries that we have to look for. And then there is many branches below the knee. You have to identify all of them, see where the blockage is, where the plaque is, how much is it. You can easily tell that on the angiograms. And then, of course, depending on the morphology, depending on the plaque, the size, depending on if there's any blood clots on top or not, thrombus formation, we have to find out what tool will work best to clean those areas and restore the blood flow.
Right. So, you talk about how can circulation be restored. Early detection or screening is obviously of paramount importance when it comes to, preventing an amputation for these patients. And, how important would you say catching peripheral artery disease is at an early stage, in terms of the onset development versus it becoming a situation where there's critical limb ischemia and now, there's immediate intervention that is needed?
Well, you have touched a very, very good point here. because once there is critical limb ischemia, then the mortality is extremely high in these patients, especially if not intervened or not revascularized. The mortality in patients with critical limb ischemia is as high, if not more, than cancers. Okay, so critical limb ischemia, when we see a patient with critical limb ischemia, that we treat it like acute coronary syndrome. For example, in the heart, if there's somebody has chest pain and is continuing, and they may end up having a heart attack, so we intervene like now. We have to get them to the emergency room or the cath lab and try to intervene sooner than later. Same thing we do with critical limb ischemia. If there's critical limb ischemia, that means the limb threatening ischemia. That means if not treated in the right circumstances and right correctly, then these patients may lose their limb, and that may require like amputation. And those are the patients extremely high risk for not only having early death, but they continue to have that risk of losing other leg. For example, if you have amputation of one leg, the study shows up to 50% of these patients may end up needing amputation of the other leg. Okay, once you have the amputation of both the legs, extremely high risk of dying. 50% of these patients die within 2 to 5 years. So it's a
So
very
that,
matter.
without being, a fearmonger, Dr. Kumar, you mentioned, the critical nature of it and the mortality rate. So it's almost as if it's a ripple effect where, the amputations happening in one leg could very much happen in the other. But I think it's quite serious when we talk about it having more or higher of a mortality rate than, most of the cancers. Because, with cancer, for example, there's a lot of material out there. There's a lot of information out of there. Patients, have, come across a lot of research where they know it's not something that's going to be elective. They want to treat it, whichever treatment they decide to pursue. It's, peripheral artery disease is something that, you don't get or much attention on out there in terms of the mass media. Is this, obviously something that's quite important. So I think that, we talk about limb loss and we talk about the severity of the, potential issue where there's a saying out there, saving limbs, saving lives. And now you kind of, have reverse engineered it very well, but what you're saying in terms of the mortality rate that leading, to death. But is limb loss really a situation where it's a failure of late stage care, or is it a situation where it could be prevented if it's early stage detection? What is your thoughts on that?
I think it's very important to find this disease early on, because if you wait until the critical limb ischemia sets in, you already have let the disease advance to a point. Even if you treat them, this disease in the small vessels comes back and you have to go back in again. Okay, so and sometimes you don't get to the full potential, or you're not able to restore the blood circulation to the point that it will last for a long time. So it's very important to prevent that stage. So early detection is the most critical part of preventing amputation, and then as a result, death in these patients. So limb loss and then life loss. Those are two very critical points that you have touched upon. And I think those starts with the early onset identification.
Yeah. So, earlier in our conversation, Dr. Kumar, we had mentioned, about patients potentially having a sedentary lifestyle. We speak about, the factors that lead to, them having diagnosed with peripheral artery disease. We spoke about the importance of, diabetic patients and, those that are smoking. We've talked about symptoms, that we've touched upon, for example, numbing and tingling of the feet and, peripheral neuropathy. When we talk about peripheral neuropathy, how does that particularly link back up to peripheral artery disease? Is that a telltale saying, basically, whereby you can, detect that if someone has peripheral neuropathy, they are a candidate for peripheral artery disease?
Oh, yes, that's very important that you touched upon. Until now, we didn't understand that well, but now we know that peripheral nerves also need blood supply. And then if there's any severe peripheral artery disease, these nerves also are not getting that much blood. And that's the neuropathy that people they don't feel. They stop having these sensations, and that's why they don't feel the pain also, by the way. As we were mentioning, most of these patients are not that symptomatic because they have the neuropathy that sets in, like especially in diabetic patients. And even though they have severe peripheral artery disease, they may not feel it. And so the neuropathy, if someone has neuropathy and they are feeling that and they are feeling off balance and they are at risk for falling and breaking their bones and hip fracture and those things that sets in. So if somebody has neuropathy, they should be evaluated for peripheral artery disease as a contributing factor, and we call it ischemic neuropathy. That can be treated, that can be prevented. We had a patient, many patients who have had, a feeling of off balance when they walk. They have to look at their feet. We go in, restore their blood circulation, and they start feeling better. And now they don't have to look down, and they are able to feel their feet, and they don't have that off balance anymore.
Yeah.
Absolutely, that's very critical to identify that as um, neuropathy can be a symptom of peripheral artery disease.
So, Dr.
One more
Kumar,
thing you were asking there, when let
right?
me just explain a little bit
Yeah, you
more.
go ahead.
See, these symptoms, okay? How do you identify these patients, with severe peripheral artery disease, the people who don't have that much symptoms? So what happens is some of these patients have leg or the foot pain, especially at night, okay? They'll have cramps at night. What happens at night when they are laying down, and if they have severe peripheral artery disease, in the daytime, the gravity continues to pull the blood down a little bit through these blocked arteries, through the extra channels they develop like capillaries.
Right.
And so the blood reaches somehow. However, at night, when they're laying down, there is no gravity that pulls this blood down.
Okay.
And look at the foot, especially the foot, when the foot is, they're sleeping like this, let's say, and the
Right.
foot is like this when they're sleeping.
Right.
So now the blood, to start with, there's significant blockage. It's having hard time going through the arteries. And
Right.
now it has to travel against the gravity night because we are sleeping like this.
Okay.
And that's when they start feeling that cramp or discomfort in the foot, and they wake up and they have to dangle their feet on the bedside, and then they have to walk around to feel better, to get that extra blood that they need
Yeah.
uh, uh, during night.
So,
Very
walking is so important, Dr. Kumar, and mobility. We talk about patients that are obese, have family history of diabetes, that are being basically living a lifestyle that is not conducive, to being healthy. We mentioned supervised exercise programs or a walking program. Would you recommend that as an important piece that patients, for example, that visit your practice or clinic should consider, depending on the level of claudication, depending on the level of leg pain or cramping? Is that something that you would advise them to be put on in terms of a what we regard as a supervised exercise program or a walking program?
Absolutely. What happens is these patients have claudication. So there are two types of patients. Here we're talking about the patients who have pain in the legs or feet on walking. Okay. Those patients we call it claudication. Exercise and supervised exercise program, those are very critical to start on those patients and see they may start feeling better. They may start developing those collaterals. They may have improved circulation. Those patients with claudication, they are not at that high of a risk for having amputation, by the way. They are not as high of a risk of critical limb ischemia. The patients who are high risk for critical limb ischemia and losing limb and leading to amputation is patients who have pain at rest or have smaller vessel disease, and they may not have claudication. They may just feel the discomfort or pain at rest or at night. Okay,
Right.
because these are the small vessel disease. These are the end arteries through which the blood has to reach the tissue. Okay, so their large vessels may not be giving them trouble. So that's a very critical point to understand. Until 10 years ago, when we talked about peripheral artery disease, we would talk about claudication and the major arteries or the iliofemoral arteries narrowing or blockage, and we would go in, do the AO bifem bypass, or put stents in the iliac arteries, and they're fine, and they do very well. Actually, still they do extremely well. That's kind of setup the patient there is. Now, over the last 10 years, this phenomena, the disease has changed because we are trying to prevent the amputation. We're trying to heal these wounds and ulcers until this technology was there that we were able to open these small arteries in the legs or even to the feet. We would have them, hey, there's no circulation below the knee, let's amputate. To prevent the amputation, now we are able to identify the blockage into the small arteries, and we are able to open them and keep them open.
So there's definitely been advances that you mentioned, from initial claudication to a situation where now it's quite severe to prevent amputation. So those are patients that are immediately at risk. So with that being said, Dr. Kumar, how much of amputation risk can actually be reduced before a surgeon is actually ever involved? We talk about the lifestyle of the patient and what they are doing, but do you feel that, patients need to look at certain factors and maybe, skin discoloration? Could it be severe? You mentioned and hit on things like rest pain at night. It's severe sort of, one foot is cold versus the other. Are these telltale sayings that, they basically need to go and look at and then make an appointment to be able to come and see a vascular surgeon or someone like, for example, yourself at your practice, so that they can go for an ultrasound and determine, what situation we're actually dealing with?
Excellent point there. How does the patient know whether they need to see a vascular specialist or not? I think that's what you are asking.
Right.
If any patient who has any discomfort, it's not a pain actually from the peripheral artery disease. It's some sort of discomfort. Why I call it like achy, heavy, tight, something maybe even sometimes burning feeling or numbness or feeling of weakness. They feel, sometimes people will say, I feel cold, my feet, even if I
Right.
put socks, it just feel very cold. And when you touch their feet, it is cold, because they don't have that much circulation. Some people will say, I'm losing hair on my lower legs, or there is discoloration. So all those symptoms that or abnormal findings by the patient on their legs and feet, or abnormal feeling, okay, they all should come and get evaluation by a vascular specialist, because it's so easy to check that in the office. It takes not more than an hour to do everything that needs to be done.
Right. So, that's the benefit, of patients coming into an OBR, or an ASC, as we say, versus going, talking about inpatient care at a hospital where it's quick, it's easy evaluated at an office visit, and they can determine that, if that is the case. But Dr. Kumar, I think it's also important that, we mentioned it at the top of the hour, foot health, and not just limb loss awareness. April is also Foot Health Awareness Month. And if you look at, patients that, have gangrene in their feet, diabetic foot ulcers that are not healing, we talk about diabetic wounds in their feet. There's been newer research, and you mentioned technologies that can be looking at treating, patients that even have issues that are, below the ankle. Can you, highlight in a bit of those, and, how important it is to look at also foot health and not just low extremity health, below the knee to the ankle?
Excellent. Actually, that's where, if we have made a lot of difference over the last few years, that's where we have made the difference. As I said in the beginning, 10, 15 years ago, we used to look at the groin and the, above the knee arteries. Now, then we started look at below the knee. Now we are looking at below the ankle circulation. And that's where the feet health is comes into the play. If somebody having difficulty in sleeping, in walking, or they have foot discoloration, or they have an ulcer or gangrene in the foot, you know that there is significant small vessel disease there, some significant circulation, poor circulation into the feet. So we can go into the feet now, we can look at those small vessels, we can atherectomize those small vessels, get the plaque out, or open and restore the blood circulation in those areas. If we don't do that, these ulcers or gangrene, they don't heal. Even if you go and let's say I have patients all the time
Mm.
where they have a, let's say, ulcer or gangrene in the big toe, and they go to a podiatrist or wherever, and if we don't evaluate their circulation, then you say, oh yes, this ulcer, let's get this off. You take that little toe or the big toe off. Now you have created a bigger wound there because these sutures are not going to heal because there's not much blood supply. And so these end up having, hey, we have to cut a little bit more. And so you take the front foot off and then the, ankle level or below the, knee. And
Mm.
this is what happens. So it's very critical that before we start using that knife, okay, we get an arterial evaluation and optimize the arterial circulation so that there is enough blood flow. And most of these patients, we don't need to do amputation. You can get their ulcers healed. Diabetic foot ulcers can heal if you get their optimized circulation.
Okay. So, Dr. Kumar, with your background as being a cardiologist, and to kind of emphasize this, do you feel that cardiologists are the missing link when it comes to limb preservation?
I think so. I mean, cardiologists, those who have been trained to treat these small blood vessels in the heart, like 2 millimeter vessels, now the same technology we've been able to bring to the legs and feet now. These vessels in the below the knee vessel, these are like 3 millimeter vessels on an average. Okay. If we go below the ankle, these vessels are like 1.5 or 2 millimeter vessels. And that's a perfect set. I think cardiologists have they've been trained. I think they have had that experience to deal with those small blood vessels because some of these small blood vessels, when you try to enter them, you take the wire there and they go into spasm. So we have special ways of preventing the spasm. We give sometimes the continuous infusion of the intra-arterial nitroglycerin, verapamil, and heparin combination. And there is various things that we can do while we are trying to navigate through these small blood vessels to prevent that spasm. We have to make sure that the blood continues to flow through them. Okay, and that's, I think, interventional cardiologists are, they have that experience from the coronary arteries that they can now deal with the small blood vessels in the foot.
Okay. So I think that, we talked about the importance of, bringing attention to peripheral artery disease. The fact that, it's about, saving limbs, saving lives, amputation prevention. And, we talk about lower extremity revascularization. But I think, to the point of foot health awareness and something that's extremely important as well, which, slightly moving the topic away from PAD, is when we look at, overall foot health. And a lot of patients have heel pain and they have chronic heel pain. We talk about how important it is to be able to let them be able to walk freely with less pain, to not to have to stand and see the sort of stabbing type of pain affect their everyday life. We've got patients out there that I'm sure you've seen that want to spend time with their kids. Grandparents or elders that just want to, appreciate the little things in life. People that are, obviously standing a lot in terms of their occupation at work, in terms of their daily, routine, or even trying to do some extracurricular activities, but they're just being impeded by the difficulty when it comes to some of this chronic heel pain. And one of the things I'd like to touch upon, which I know your practice, Dr. Kumar, specializes in, and you see a lot of patients are when it comes to pain regarding the plantar fasciitis, right? And, in terms of how they feel that discomfort. With that being the case, is there something that you'd like to highlight that patients need to, be cautious about or look at, looking in terms of symptoms that could determine if they actually have a major concern when it comes to the pain with regards to their plantar fasciitis? And is there any type of treatment out there, for example, maybe an embolization or so, that they could actually come and look at being seen as a need to assist them with regards to this pain?
Excellent, excellent. Actually, this is the latest field to treat the chronic inflammation. See, plantar fasciitis is the chronic inflammation of the heel, same way as we deal with the, let's say, knee pain, and chronic inflammation is the one that tries to heal these areas wherever there is a problem in our body. See, what happens is, let me take you back to the this concept of how we are able to treat this chronic inflammation, like the joint pain, for example, the knee joint, hip joint, shoulder joint, plantar fasciitis. The problem is the same in most of these areas. People have pain, they are not able to function, they feel the stiffness, they cannot walk. When they wake up, they cannot take their foot on the floor, they start feeling pain, or like they have that stiffness, they try to get in and out of the car. It is the chronic inflammation that is causing most of these symptoms. Okay? And the chronic inflammation, we did not have much idea how we can see that chronic inflammation on the angiograms. Until now, if there's an inflammation, we give them the anti-inflammatory medication, which is non-steroidals that have been the case for a long time. If the medications fail, we give them injections of the cortisone, which is also act as mostly the anti-inflammatory medication. So we try to stop or reduce the inflammation, and patients do feel better for some time. However, this is not a long-term or long-lasting solution. Now, what we have found is, what is this chronic inflammation? And I'm going to show you a quick picture on my poster I have here. I don't know if you are
Okay.
able to see that well, but
Yes.
this is a plantar fasciitis patient we treated. And you
Okay.
see, this is the heel, and this is our catheter. And you see how this blush here
Hmm.
circle?
Right. I can.
So we see the chronic inflammation now is seen as, because this is the neoangiogenesis and the small blood vessels. Just like here, you can see that this is like these are the normal blood vessels, but this is like, the circle here. These are like a new tiny blood vessels that form to help with the pain and chronic inflammation. But this itself begets the chronic inflammation. So now we have identified, hey, the problem is right here. This chronic inflammation is what is causing the problem. And so we are able to identify that on the angiogram, and then we stop the inflammation by injecting small, tiny microspheres into the small, tiny blood vessels. And you see that result here. See the
Right.
difference?
I can see
This
that.
blush is gone now. And these
Yeah. The
patients
chronic
start feeling
inflammation has subsided and the blush is now being, removed. If you look at
right.
pre and post.
And interesting thing is, these patients start feeling the difference within the next few hours, or by the next morning, they say, "Oh, I'm feeling wonderful." Same thing is for the knee joint, for example, right here. How does the inflammation looks? We didn't know how to look for that until a few years ago, and now that we know these tiny small blood vessels, they're like less than a millimeter blood vessels. We enter those arteries and these branches. We check and see that inflammation here, and we inject microspheres, and that stops the inflammation.
Okay.
And so what we are doing is taking away this new angiogenesis or new small tiny blood vessels. We get rid of them, and this stops the inflammation. That's how the patient starts feeling better. This is the amazing new discovery of the last 5 years, I would say. There's so much that Dr. Okuno has added to the field of this chronic inflammation. Dr. Okuno is the interventional radiologist from Japan.
Right.
Uh, I met him about a year ago, and then I have met him several times since, and learned what he did was he was not actually looking to treat these patients. He was working on chronic inflammation in the animal model, and he found out, hey, how does this look? And so he found that this is how the chronic inflammation looks. And so then he closed this inflammation with various different things, and he found out these animals, they can start walk, and they start walking better.
Okay.
Then the government of Japan allowed him to treat some of these patients. It's not like FDA here.
Right.
It's a little bit easier. And then so he treated, and he found, oh my God, this is a miracle treatment. He started to do some studies, and now once he was confident that this works, that started to happen somewhere around 2019. Then people in rest of the country started to get an interest in that, and for the last 3-4 years, now it's a very common mainstream treatment for treating these patients.
Yeah. I think that, you mentioned chronic inflammation and being the root cause, a lot of these issues when it comes to, foot health, joint pain. And I think that, you have patients that you see on a daily basis at your practice that have tried, the traditional methods. And, you've realized and assessed that, after a period of time, these are not working. So can you share with our, viewers and our listeners of any cases that stand out when it comes to peripheral artery disease and trying to prevent amputation, or as well as foot health awareness when it comes to plantar fasciitis? That is something that will be more reassuring for them to realize that these have been the results ever since the patient has come through to you.
I had a patient who had multiple surgeries, a young lady in her early 50s. A podiatrist sent her to me, and when he heard about that, this is something that can be done. So when I saw her, she had multiple surgeries and injections of the last 20 years of the
It's a
heel,
long time.
and was
It's a long time.
miserable. Then nothing was working anymore. Okay.
Right.
And so when we saw and we treated her with this simple procedure, took about 15 minutes to do it. Uh, and it made a huge difference in her, the way she was able to walk, able to sleep better, able to function better. That it just makes us feel wonderful about it.
Yeah, that's so important because here you've got into the business of medicine to treat patients. You fell in love with it. You've been doing it for so many years. And I think that, overall it's important because, having good bedside manner is one thing as a physician when a patient's coming to you. Having, information out there as a lead source whereby, you have referrals from other physicians, or you have, potential patients going online and looking at some of the reviews. I think it's so important that, patients feel comfortable, when they come over to a provider and they have that reassurance where they can basically see the proof is in the pudding. From the time they, enter a practice, from the, interaction with the staff at the front desk to the time they meet a provider. Is there any parting or last words that you would be able to, provide out there with your expertise, coming from this field that you can, give us reassurance for patients that are experiencing issues with regards to peripheral artery disease, that have issues that are concerning them, and you don't want it to be a case where it leads to limb loss, or patients out there that are having issues with regards to their, health of their feet, and how impactful or devastating that has been for them to continue with their everyday life. In conclusion, is there any parting words that you'd like to share, Dr. Kumar?
I just like to say that a lot of patients and doctors don't know about these recent treatments available for patients with these chronic disabling conditions. For example, the joint arthritis, anywhere, whether shoulder, hips, or a knee, or like plantar fasciitis. I think I like to tell our viewers that the if any of you or your near and dear ones have any issues with joint pain or foot pain or difficulty in walking or having any pain, please, before you get that organ removed or replaced, for example, knee replacement or shoulder replacements or hip replacements, I think this is something, a wonderful new uh, I would say, a bridge, that we can walk on, or we can take the advantage of this new therapy that's available to reduce your pain and suffering. And let's say for about 10 to 15% of the patients, these procedures don't work. Those are very simple, easy to do. There is no significant complications. So if these don't work for you, you still have the option. You've not lost anything. You still have the option of getting the knee replacement or hip replacement. But I think if someone is suffering with these symptoms or this chronic disabling arthritis, they should get the advantage of it, see a vascular specialist in your area who deals with these conditions. And there are more and more people now doing this treatment.
Okay. Well, thank you so much, Dr. Kumar. It's been a pleasure having you as a guest, providing such great insight and expertise in the field that you are a leader at. And I look forward to connecting with you again. And thank you so much for making the time.
Oh, thank you very much, Wayne. Really appreciate you've been wonderful. Thank you.
Thank you, Dr. Kumar.